All right, like John said, I'm going to try to keep this short. So you're going to hear from the U.S. and Canadian perspective on kind of what how we measure quality now, or how we're measured externally now. So my disclosure. So as far as coming here and talking about quality, I think everybody in this room probably has heard this gentleman's name, Dr. Donovan Z. He was at the University of Michigan, and in 1966 he wrote a seminal paper kind of talking about this conceptual framework around quality, structure, process, and outcomes that has really become a part of the vernacular around quality measurement. So I'm going to touch on each of these pieces. And one of Donovan Z's messages was that each of these in and of itself can't be a quality measure by itself. You've got to think about the entire spectrum from structure, process, and outcomes, and how all those three interplay and work together. And unfortunately, right now, we do look at these as silos. So as far as structure, I mean, the big thing is really there's two areas that have been commonly discussed recently, and things that are two areas that we're being measured on. One is around EHRs, part of the MIPS program, used to be called Meaningful Use, and that's through CMS, as well as ICU physician staffing. That's part of the Leapfrog group, a couple groups I'll talk about in a second. But structure really is kind of what are the resources at your institution, what is a staffing model in your institution or in your clinic, what are that may contribute to the quality spectrum. As far as process, it's a little bit self-explanatory, but this is something that has gone by the wayside a little bit. You guys all probably remember SCIP measures. They were around perioperative MI, DVT, and surgical site infections. Those have kind of faded a little bit. The VTE ones have really stuck around for a while, but they're really all around what are you doing to prevent complications? What are you doing upstream of those outcomes that we're measuring to minimize harm? And Hospital Compare, like John was saying, is another website you can go to, is publicly reporting how your hospital is doing currently on several of these measures. And it's also tied to money. It's tied to reimbursement. So Medicare uses these measures, these process measures to determine payments to your facilities. Leapfrog group is another area where there's being some public reporting. Hospitals participate voluntarily in these hospital surveys, and you're getting graded. You're getting literally an A through F grade, and if you're not aware of that, you can go to Leapfrog's website and see how your hospital's doing on several of these process measures that feed into these letter grades that end up on a lot of billboards. As far as outcomes, that's obviously what we all kind of understand the most. I think it falls into three buckets. First is really morbidity and mortality. It's kind of classic outcomes that we think about. Patient-reported outcomes have really been on the rise in the last few years. And then cost is really the big one that's also being publicly reported. Morbidity and mortality, again, we have a couple ways that you're being judged externally. NSQIP, that is at least somewhat private. But Medicare, again, is publicizing your hospital's morbidity and mortality, where you rank amongst other hospitals in the country. Patient-reported outcomes, HCAHPS scores, I know everybody hears about that. It's kind of every chief, what do you call them, patient officer's dream is trying to get the HCAHPS scores at your hospital up. Those are also being publicly reported. We know those aren't perfect, and there's been a lot of patient-reported outcomes through the PROMIS group that are out there for use, and people aren't necessarily using them well. They're not really publicly reported yet, but they will be at some point. And cost, this is the scary one. So Hospital Compare now publishes your average national payment for several procedures and medical diagnoses, and they're really assigning value star grades to you and your hospital. And so here's the University of Michigan's, I guess we're less than the national average payment for hip and knee replacement. But these things are going to start to become part of the discussion more publicly. So I just want to kind of emphasize thinking about these three areas, not as silos, but as factors that interplay with one another as we measure quality.
Perfect. Thanks very much, Amir.
Great. Thanks, Amir.